sir, we are live now, sir.
Okay, very good. So, hello, good morning, good afternoon, and good evening to our distinguished speakers, chairs, and audiences of ACNS-YNS webinar from different parts of the world. We are yet back again with another session of educational lecture for you to promote the neurosurgery education in low-resource countries, and this episode is to encourage the education in Afghanistan, Latin America, and Caribbean. The invited expert speaker for today's webinar are Professor Hidayuto Kimura, who's going to talk on virtual demonstration of bypass technique, and Professor Soichi Oya, who's going to talk on surgery for meningiomas. And the young neurosurgeon who's going to present an interesting case for the debate is Dr. Rihanna Ghaffari from Afghanistan, and she's going to have an interesting case about how to manage intracranial tumors in pregnancy. Along with that, we have our chief patron, the president of ACS Society, Professor Yoko Kato, and two co-patrons, Professor Fawad Pirzad, president of Neurological Society of Afghanistan, and another co-patron, Professor Federico Saleh, the president of Uruguayan Society of Neurosurgery. So on behalf of ACNS-YNS committee and Professor Yoko Kato, we welcome all the speakers and audiences to this educational online platform of ACNS-YNS webinar. And the moderator for today is Dr. Nujerling from Dominican Republic, Dr. Nadia from Peru, Dr. Ahmed from Afghanistan, and myself. And soon my co-moderator, Dr. Liu, also will be joining us. With that, may I request Professor Yoko Kato to please say some opening remarks. You'll have to unmute.
So hello everyone. So welcome to our again the YNS webinar. So today we'll have a very good teachers. Both are from Japan, and Dr. Kimura is expert of the bypass, and also Dr. Oya is expert of the skull base, but he can do the cerebral vascular both. I think we are very much expecting their lectures. And also the YNS. Dr. Hannah from Afghanistan. She is really dynamic and very active. And also from Dominica, Dr. Nujerling. She is a really very nice, very good lady neurosurgeon. I expect everybody their speech. Thank you very much.
Thank you, Professor. May I request Professor Pirzad to say a few opening words, please?
Hello.
Hello.
Good morning, good evening, and good afternoon for everyone. Ohayou gozaimasu. Thank you very much. Thank you, Professor Yoko Kato, Dr. Sachin, and all colleagues for supporting Afghanistan and low-income countries and low developed countries. Thank you very much for supporting, for your continuous supporting Afghanistan and Afghanistan neurosurgery and also Afghanistan women in neurosurgery. We proud of you, and we remember all of your effort for supporting Afghanistan people through supporting neurosurgery in Afghanistan. We are grateful of you, and thank you for such webinars for young Afghan neurosurgeons. And see, we have a lot of colleagues from Afghanistan today. Thank you very much. And for all over the world, neurosurgeons, young neurosurgeons, they are present today. Thank you very much.
Thank you.
Arigato.
Thank you. Thank you, Professor Fawad Pirzad. It's always very pleasant to listen to you. Thank you very much. So with that, we'll start our lectures. May I request Dr. Nujerling from Dominican Republic, please kindly introduce Professor Hidayuto Kimura and do the favor, please.
Yeah. Good evening from Japan and good morning to Latin American countries, also my country. And today is more than an honor to me to present Dr. Professor Kimura. And his current position, he is a professor from the Department of Neurosurgery in Kobe University. And he has special interest for vascular microsurgery, aneurysm, and vascular anastomosis. And today we will have a very interesting lecture about virtual demonstration of bypass technique. So Professor Kimura, it's your time. Thank you.
Thank you, Dr. Nujarin, and share my screen. Can you see my screen?
Yes, Prof, it's visible.
Okay, thank you. I'm Hidehito Kimura. It's my very, very great pleasure to be invited again here. And I deeply appreciate Professor Yoko Kato and Sachin and all of our colleagues for inviting me. Yes, it's my great pleasure to see you here. Today, my topic is virtual demonstration of bypass technique. So maybe the younger neurosurgeon is not not familiar with bypass techniques. So first, every young neurosurgeon have to know the actual bypass technique, how to perform their needle insertion, how to perform the training. It should be known. So today I will talk about this content. First, what is the Sdmc anastomosis? Superficial temporal artery anastomosis to the middle cerebral artery. How to perform? I will show you in the actual surgery, a step-by-step instruction. After that, I will show the actual training, how to perform your training in a after your daily surgery. Here, this is our first, I will talk about Sdmc anastomosis. In this surgery, this is my illustration, and two superficial temporal artery were harvested and the craniotomy. After that, the two STA, or sometimes, of course, single anastomosis is okay, and single STA anastomosis to the superficial middle cerebral artery, so-called M4 portion of the middle cerebral artery anastomosis. At first, you should try one single anastomosis, no problem. But as you get accustomed to doing, you can perform the double barrel anastomosis as shown in this slide here. And what is the indication for this bypass? The bypass surgery still needs to be done for the patient with progressing ischemic stroke and Moyamoya disease. And sometimes when you perform the complex, difficult cerebral aneurysm, you should perform the bypass surgery prior to the approaching to the aneurysm. And in the less chance to perform in the radical resection for the skull-based tumor, in removing a skull-based tumor involving the internal carotid artery or something like that, you should perform the bypass surgery prior to the removal of the tumor. For the ischemic patient, so as you may know, there's two prominent randomized trials failed to show the efficacy, superiority of this surgery over the medical management. In the so old 1985 or more recently 2011 was in the United States. Our colleagues, of course, performed the bypass study, but they failed to show the efficacy of this bypass. So the chance of to perform the Sdmc bypass is decreasing after that this publishment. But in Japan, we so-called JET study, Japanese ECIC bypass trial. Unfortunately, this final result has not been published internationally. However, we have a Japanese in Japanese result we just have here. But in detail, in short, I will explain about in the content of this study. So in this JET study, we just proved the efficacy of the Sdmc anastomosis for the patient with atherosclerotic disease patient. So this is the inclusion criteria here. So the patient suffering the internal carotid artery or middle cerebral artery occlusion or severe stenosis, and the patient just suffered a mild transient ischemic attack or mildly severe severe infarction, and so kept the patient still a modified Rankin scale less than 2, and cerebral blood flow should be done, if possible, even in the developing countries. So, but if without this SPECT study, you can choose the patient, if the patient suffering the ischemic hemisphere or not. So, in using the SPECT study, this is a quantitative CBF study by iomazenil acetozolamide activated SPECT study. The left side is at rest study, and Diamox activate the study is right side. In the rest situation, even in the rest situation, the diseased hemisphere was decreased blood flow, as you can see. And usually, in the best candidate for this surgery is less than 80% of the decrease compared to the normal hemisphere. And after that, Diamox activated cerebral blood flow increase is less than 10%, is good candidate for this patient, for the bypass candidate patient. The first, we have to know the principles of the bypass surgery. This is a very, very important point to perform the bypass surgery. The first, that temporary clamp time of the recipient artery should be as short as possible, of course. When you're clamping the recipient artery over the brain surface, the blood flow is not no flow. So the longer clamping time may cause to the cerebral infarction. So to avoid this surgical complication, the clamping time should be as short as possible. And second, do not pinch the intima directly using the forceps. Usually, without this notice, with care, surgeon may tend to pinch the intima directly using the forceps. Sorry, here, just pinch the intima. The intima can be easily disturbed, and the platelet aggregation will occur easily, and finally the bypass will occlude it later on. So to avoid the occlusion of the postoperatively, do not pinch the intima directly using the forceps. And let the intima making an eversion and facing each other like this. And if you need insertion too far away from the cutting edge like this, the adventitia usually come into the lumen. And here is a platelet aggregation will occur easily. To avoid this inversion, just making the eversion like this is very important. To make this eversion forming, needle insertion point is very important. I will explain about it later. The first I will explain about using the actual surgery. The skin incision, here I show the 2 superficial temporal artery course here. If we perform the single anastomosis, single Sdmc anastomosis, you just make a linear skin incision just above the parietal branch of SDA, like here. You just make a small skin incision, not small, but a simple straight skin incision can do well for this bypass surgery. So you need just make a skin incision like here, and a small craniotomy, open the dura, and you will find a good recipient around here. Therefore, if you perform the double barrel anastomosis, for the ischemic patient, you can make a 2 linear skin incision just above 2 STA superficial temporal arteries. The for Moya patient, like here, sorry. We also need to perform the so-called encephaloduro-myo-arterial-pericranial synangiosis. To perform this indirect anastomosis, we should make a large craniotomy. Okay. Large craniotomy. So, and of course, we should perform the double barrel anastomosis. And so making a large skin incision like here, and the skin flapper reflected anteriorly, and 2 STA were harvested, and double barrel anastomosis. After that, temporal muscle and pericranium and the fascia is also implanted on the brain surface over the covering over the brain surface, exposed brain surface like this. This so-called indirect anastomosis. For the patient with Moya disease, we usually perform the indirect anastomosis on the indirect anastomosis both combined. So to perform combined revascularization, we should make a large craniotomy like this. For the patient with a ischemic stroke patient, this patient is a 65-year-old male gentleman, and the transfer to our hospital, and he had a left mild hemiparesis, and he had a history of diabetes mellitus and hypertension. It's a common situation. The diffusion weighted image demonstrated so small a high signal region at the MCA territory like this. And a magnetic resonance angiography demonstrated right internal carotid artery, severe stenosis. The middle cerebral artery also signal intensity is decreased lower than the left side. The spectral study showed impaired cerebral blood flow and the middle MCA territory, right middle cerebral artery territory. So we performed the patient to perform the Sdmc and Osmosis emergency. The patient, as a patient position spine, the head was rotated about the contralateral side 60 or 70 degrees. And just make a skin incision, linear skin incision, just above the STA. Usually I harvest the STA under the using a microscope, paying attention to the superficial temporal artery, not to damage this artery. Taking care. Using a bipolar, we call this technique bipolar cutting method. High power coagulation method. Perivascular tissue can be coagulated and cut simultaneously. SDA can be harvested about 7 or 8 centimeters. The heparin solution was injected from the end of the graft to avoid the intraoperative coagulation. The temporal muscle was cut and the relative small craniotomy was performed. And dura was opened, choose and find the recipient artery. As strong, as thick as possible is better for the patient to perform. Once you select the donor artery, recipient artery, and making the trimming of the end of the donor artery, making a fish mouth trimming to make good aperture. Before clamping, I'm insert needle in tensile nylon, using a tensile nylon, inserting the end of the STA. the needle insertion should be performed the highest magnification, and the tying the thread is the lower magnification. In this surgery, you can change the magnification appropriately, frequently and appropriately. Needle insertion is a higher magnification, and the tying the thread is a less lower magnification. And every needle insertion should be done carefully, confirming the lumen. Needle tip is actually and definitely inserting the lumen, and you can penetrate the visceral wall, inside, outside. Checking lumen is important point to perform the needle insertion. After compression of the bypass, the clamping is a distal and the proximal and the donor artery in order. And using Doppler and confirming the blood flow, and recently I used, of course, ICG video angiography demonstrated, and the patency of the graft. And they are closed. After the replace of the bone graft, again, you should check the patency of the graft. To avoid the CSF leakage around the graft, you use a first year. Recently, I use artificial dura material around here, so-called duragen around here. And the important point is not to compress the graft directly, but to avoid the CSF leakage. Bone flap is trimmed appropriately, not to compress the graft. And the temporal muscle is also cut it, incised, not to avoid the compression of the graft. By the end of this surgery, you should care, every time you should care for the graft, every time. And post-operatively, the patient suffered no neurological deficit and no CT, no hemorrhage, and the MRI demonstrated, and good patency of the STA. And next, the spectral study shows the improved cerebral blood flow in the diseased hemisphere. Next patient is a Moya patient. This patient is a 17-year-old female suffering the transient hemiparesis. And she had no neurological deficit at the outpatient department. This is CT scan demonstrated, and the small low signal and low density area at the frontal lobe. And then FLAIR image demonstrated also the frontal lobe was showing was a high signal region showing a low perfusion, implying a low perfusion. And diffusion weighted image, a little bit subacute phase of the cerebral infarction occurred. And magnetic resonance imaging, angiography demonstrated Moya disease. Internal carotid artery was bilaterally occluded, and the basal Moya you can see in this even in this magnetic resonance imaging. And the digital subtraction angiography demonstrated. This is the right side, and this is the so-called Moya. You can see the Moya pieces like here, and the basal Moya vessel is developed well. And this is like external carotid artery angiography demonstrated. You can see the two superficial temporal artery like this. And this is the left internal carotid artery angiography showed that, of course, this side is the ICA was occluded at the terminal of the internal carotid artery. And Moya vessel can be visualized. So the patient was diagnosed as Moyamoya disease. The SPECT study showed the markedly decreased blood flow in the cerebral hemisphere bilaterally, you can see. The right side was more markedly affected than the left side. The acetozolamide activated image showed, of course, impaired vasoreactivity bilaterally. The right side was more markedly affected than the left side as well. The quantitative analysis demonstrated, of course, that markedly decreased right side than the left side. So we performed the right Sdmc double-barrel anastomosis and encephaloduro-myo-arterial pericranial synostosis was performed. As I mentioned, skin incision is like here. The large question mark shape skin incision was made. And to harvest the two STA superficial temporal arteries. As I mentioned, using under the microscope, I harvest the two STAs. Just under the parietal, just as under skin incision, parietal branch was harvested using the bipolar coagulate cutting method. The frontal branch can be harvested from the backside of the skin flap under the garrier. You should harvest the ST as long as possible, of course. But usually the frontal branch 6 centimeters is okay. Sorry. And there are, slow video. And to perform the ED maps, encephaloduro-arteriosynangiosis, the temporal muscle and the fascia and the pericranium is inside like this. So the stopped. Sorry. Moving on here. And yes, and the temporal muscle is also cut. These muscle and the fascia will be used after the anastomosis. And the front side of the pericranium is also refracted anteriorly with a pedicule. And a large craniotomy performed. Sorry. Under the microscope, it dries incised. And to keep the patency of the middle meningeal artery, dries incised and dries inverted inside the subdural space. Arachnoid is cut. Once you found the MCA, the rubber seat is placed under the donor recipient artery. As you can see, the STA is so narrow compared to the atherosclerotic disease. The clamping the recipient artery and using the 10-0 needle. As I mentioned, needle insertion should be done under the highest magnification, and the tying thread is a lower magnification. confirming the lumen is also important. The tip of the needle, inserting the needle and the tip of the needle, you are paying attention to the lumen. After the compression of the pipe osmosis, open the declamp of the artery, and distal side, and the next front proximal side, finally the donor artery recanalized. Using the ICG video angiogram demonstrated good patency. This is the second anosmosis. As you can see, for the patient with moya disease, the supracortical artery, middle cerebral artery, M4 portion is very so narrow. So sometimes you hesitate to anosmosis here. So, but in that situation, in that situation, single anosmosis, no problem. Okay. This is my comment. But usually I perform the more than double barrel anosmosis. After the ICG video angiography demonstrated good patency, both graft. And using the frontal pericranial is covering the frontal lobe, and the temporal muscle is covering the parietal of the temporal area, and the frontal fascia is covering the just around the tip of the temporal lobe. That's bone flappers repressed again and closing as is a usual manner. The postoperative CT scan, no hemorrhage or infarction. Bone CT is shown here. Is a good repositioning is okay, and the CT DSA shows there are good patency of the two bypass graft. So next I will talk about that how to perform the training for the bypass surgery. Just start in we just perform start to using the artificial visceral, but without this artificial visceral, you just prepare for the chicken wing. Later I will explain about using the chicken wing training. But I will show you the using artificial visceral. The place artificial visceral like this. Using the pin, the recipient artery should be appropriately fixed. Don't mobilize. The fix is very important, of course. In the actual surgery, of course, fix the recipient artery is very important. Mobilize recipient artery is so difficult to anosmose. Fix the recipient artery. And donor artery should be appropriately. Too short, too long is, of course, not good. Appropriate length should be made, should be prepared for the anosmosis. And the end of the donor artery cut in 60 degrees, and the same length should be additionally incised. We call this technique fishman streaming. Like this. And the incision length of the MCA recipient artery should be matched definitely with the stamp of the length of the SDA. Definitely matched the same length, of course, important. Also, make stay sutures on the both ends, like here. Outside, inside, and inside, outside, of course, important. But during this procedure, for the beginner, a little bit confused to perform, how to perform. Also, you should in my mind, keep in my mind, outside, inside, inside, outside, very important. And the next suture should be done just adjacent to the stay suture. We call the 1 o'clock or a 5 o'clock, just adjacent to the stay suture is the next suture after the compression of the stay suture. And the interrupted suture is done using the usually 10-0 nylon, like this. Another important thing is the insertion point of the needle. As shown here, the needle suture insertion distance from the edge is usually should be as the same as the visceral wall, visceral wall thickness, like here. The interval of the stitch should be twice as the blood vessel thickness, like here. This estimation, just estimation, that's the important point during your procedure. This is an actual training kit. The artificial viscera placed on the tissue box, just on the surface, and another artificial viscera was placed on the floor of the box. Attach the single artificial visceral blood vessel at the bottom of the box, like here. Using this training kit, of course, using in the operating room microscope, you can change the magnification appropriately, lower and higher. In my younger age, I trained this technique after daily surgery before returning to my home. Training. As I mentioned, the needle insertion just perform the stay suture. A next suture should be made just adjacent to the stay suture. Every needle insertion confirming the lumen appropriately, and the insertion point is not so away from the edges. Okay. After that, I will cut the recipient artery and confirming the lumen. You can feel. When you finish several times, you will know you can good technique. And without this artificial viscera, just using a chicken wing like this, you can place the chicken wing over the table, and inside here, you can harvest the radial artery and the ulnar artery like here. You can just harvest two artery under the microscope. You can train the visceral osmosis like here. Just prepare for the 2 forceps and the 10-0 nylon and the micro scissor. You can train the osmosis training in your OR. Okay, like this. Okay, this is my take-home message. In order to perform a safe and reliable biopsy, the lumen must be properly checked and the needle must be passed through all layers. Create a bloodless surgical field for full visibility of the anatomical structures, not only the bypass surgery, but also all neurosurgery surgical procedures. The frequent training by yourself is mandatory to become a good bypass surgeon. Thank you for your attention.
Thank you very much, Professor Hideito Kimura, and thank you very much for accepting the invitation at the 11th hour. I'm really obliged to you. Now the floor is open for discussion. Any questions from the moderator, Dr. Nujerling or Dr. Nadia or Dr. Ahmad?
Yeah, I have some. Hi.
Hi.
Professor Kimura, thank you for your lecture. It was very interesting. I have a few questions. You mentioned at the beginning that there's a trial made in the United States, and you said they report that it's much better to perform surgery than treatment. And also you said that in Japan, there's a trial too, but it's no publicate yet. So what about Japan? What was the experience in this area? Is better medical treatment or is better to perform the surgery?
Thank you, Nujerling.
Yes.
And, yeah, you have good point. Sorry, you can hear?
Yes, perfectly.
Okay,
Thank you.
okay. And yeah, but in the study performed in the United States around 2000, it's post-operative complication is a little bit higher than in Japan. We perform in Japan. So the bypass patency and the bypass technique is very important, of course, to perform that the ischemic patient to bypass surgery. So good skill and appropriate result is very important to
Ya,
perform.
entonces mañana interconsulta.
But, of course,
Carlos, que sí, la presión alta.
what is the important point is severely select the severely disturbed blood flow patient you should choose. Especially in the patient that has the small area, just a small area of the diffusion width image high signal region, fresh infarction, but the blood flow main trunk is internal carotid artery was occluded completely. So you can imagine the patient may have a severely impaired cerebral blood flow compared to the area of the cerebral infarction. Patient suffering just a small area of the cerebral infarction, but the ischemic region is expected to larger. So in that situation, you should perform the bypass surgery. You can save the patient more greater, larger the infarction to avoid the larger infarction. In the acute phase, we should perform. We sometimes perform the bypass surgery to avoid the enlargement of the infarction area. So choosing is very important. Selection is important. More severely disturbed cerebral blood flow. So in Japan, we have a spectre. So in such a situation, we can perform the spectre study. It will demonstrate the more severely disturbed patient, even in the acute phase.
I understand, perfectly clear. And the other question is, Professor, so here in GK University Hospital, most of the time, the residents, we train with the chicken wings, or also we can use microtube. And sometimes we don't have the table microscope is occupied for another person. So do you recommend to use like lupa for training?
Lupa.
Yeah, lupa. Because for example, in Latin America, maybe not everybody can buy like a table microscope. So I was thinking like it is possible to use like a lupa for training, or maybe no.
Maybe just using a lupe is it's just have a less magnification to anastomosis. Yeah, just using the low magnification look is for you is good, maybe okay, but up to the for the yes, you can visualize the lumen of the STA well, no problem using a lupa. But just under the lupa, I have ever performed using a lupa to perform the bypass, but yes, if you can visualize the lumen well and needle insertion to try, no problems. But
because
yes.
few weeks ago, all the microscope here were taken for the students.
Yeah.
So me and my other colleagues, we said, oh, maybe we should try with lupa. So I was thinking maybe if not possible to have the money to buy a table microscope, maybe in the future. It's useful to use the lupa. Thank you very much, Professor.
Yeah, try training. Any kind of material. Yes. Even using a lupa, it's okay, maybe okay. To try, start your training is very important. Thank you.
ありがとうございます。
Thank you. ありがとう。
Thank you very much. I think a good quality loops can be a good alternative initially for the training. But I think when you're doing a high flow anastomosis, it's a big challenge. For low flow, maybe you can get away, but high flow anastomosis is a challenge. So I can see two hand raised by wonderful ladies, Dr. Nadia and Dr. Chen. Dr. Nadia, go ahead.
Good morning, good evening, everyone. Dr. Kimura, yes, have two questions.
Yeah.
First of all, very fast questions. First of all, you talk about a temporary clamp of the artery. You told that it should be very fast, the clamping of the temporary artery, that it should be a short time. Do you have an estimate time that we should clamp it, or what that is the average time?
Yeah. Okay. My expert, my teacher told me just clamp less than 20 minutes. 20 minutes. But for me, maybe sometimes 20 minutes very difficult to complete the anastomosis. So I talked to my resident on just within 30 minutes. 30 minutes, okay. Don't rush. To appropriate needle insertion, important. If you need more than 30 minutes, maybe okay. Just accurate needle insertion and don't occlude their anastomosis post-operatively. Accurate needle insertion, definite needle insertion, important. Don't rush. If possible, within 30 minutes is okay. And sometimes it takes longer than the 30 minutes. Maybe it's okay. But 50 minutes and 60 minutes, 1 hour is not good for the patient. Just my recommendation. Yeah.
Okay, and another question. I saw in some of your videos that you left a drainage to your patients. Is that something you usually do? Why you left the drainage there for some reason to protect the anastomosis, or for some reason, for not some other reason?
Drainage patient, yeah. I usually don't use sometimes I use subcutaneous drainage post-operatively. But large craniotomy, large skin flap, usually place drainage one night, just only one night.
Just 1 night, just to protect the anastomosis.
Yeah.
Okay.
Yeah. No need. Yeah.
Okay. And what Nigeli said, it's quite true. Here we have a very difficult to have microscope to training. It's sometimes even have difficult to have microscope in the hospital. So we use loops.
Yeah.
A lot of us try to buy loops for training. So sometimes that's the only thing we have to train, especially residents. Yeah.
Yeah.
So
yes. I will change my opinion. So maybe it's okay. Maybe okay.
Yeah. So I saw your box, the training box, and the first thing I saw is like send it to the residents of the hospital and say, hey, look, that's what you can do in chicken wings, and that's what you can do.
If you want, I will do a video for the training. Using box. Yeah, no problem.
Yeah.
Please show them. Yeah, thank you.
Yeah.
Yeah.
Thank you very much.
Thank you.
Thank you.
Thank you. Thank you, Dr. Nadia. Dr. Nadia is a young neurosurgeon from Peru. Nice to have you, Nadia. Dr. Chen, can you introduce yourself and ask your question?
Yes. Thank you for your Kimura, your wonderful lecture. Yeah, I want to say hello again to you.
Yeah.
I'm so happy to see you in this webinar. Yeah. We met in several years ago in Shanghai Renji Hospital. Yeah. I was your translator with your Mandarin for the same class for your vascular surgical course. Remember? Yeah. So you are a fantastic microsurgery, vascular surgery training mentor. Thank you, mentor.
Thank you.
Okay.
Thank you.
Okay. I have a small question. How to prepare the graft, the lens? How to prepare the lens when you separate the vessel? It's too long or too short is not good. So how to measure the length you need in the operation?
Yeah, usually 6 centimeter or 7 centimeter is okay to perform, but it's too short is of course not good. Yeah, the longer length of the graft you can appropriate to trim the length, but too short is not good. And usually I harvest the ST to 6 or 7 centimeter.
6 to 7. Oh,
But,
okay.
yeah.
Thank you. And if in case of we make a mistake as a young neurosurgery, we made a wrong suture and made the luminal hurt, or we have to cut the anastomosis and do it again. Is it okay?
Oh, you mean the longer incision of the recipient artery in the after clamping of the recipient artery?
I mean, if we make a mistake when we do the surgery, if make the luminal occurred, sometimes occurred, so we have to cut the anastomosis and do it again. So is it a danger to the patient? Do we have such experience?
Yeah. So after your completion of the anastomosis, sometimes in the rest of it's often occurred intraoperatively, you mean? So
yeah,
and in that situation, clamp the recipient artery again, recipient artery and again, and cut the thread and open the lumen and flush the lumen, and you find first you should check the patency of the donor artery and the recipient artery blood flow by removing the temporary clamping time clips, and again clamp the recipient artery, and in that situation usually the intima was injured, so here the platelet aggregated, and a small tiny additional incision around the intima, and you can see the intact intima. So intact intima you should confirm and trim the edges and small trimming of the recipient artery, and finally just before being re-anastomotic trial you should confirm the intact intima around the recipient artery like here, and you should try again the anastomosis. And I usually use the heparin administration, systemic heparin administration, to avoid the recoagulation of the anastomosis.
Okay, in case of we cut the bad anastomosis, the vessel length becomes short. It's too short.
Oh,
so it's too short.
How
can we do too short?
So is that to avoid the situation, the longer donor artery at the first is very important. Sometimes the tortuous donor artery in the anastomosis, maybe it's no problem.
Oh, okay. In case of this the reception and this the donor, we have to cut the reception and the donor. This is the fish mouth. Anastomosis is bad. We have to cut out of the bad one. We want to do a perfect one. So the receptor vessel becomes short.
Yeah.
How can we fix it? Yeah. We have to do another graft as a reception, right? It's a very tough case.
Yeah, very tough case. how to recover that situation. So maybe the proximal side of the anastomosis, maybe antegrade blood flow may be secured, and distal blood flow should be revascularized appropriately using the additional bypass of distal side of the anastomosis portion.
Another side. Use another side?
Yeah, distal side. Yeah, occlusion is here, and distal side is re-anastomosis should be performed. Yes, if there is no appropriate length of the donor artery, maybe so difficult to revascularize the distal side of the recipient artery. But if you have some enough length of the donor artery, and you just perform the distal side of the donor recipient artery, should be re-anastomosed using the donor artery.
Okay, and how is another side of the vessel? We need this
proximal side. Yeah, proximal is just expect to the enough blood flow from the antegrade flow. But that I mentioned. Yes. So both side revascularization is at the same time is very difficult.
Okay.
But yes, okay. But the first trial is just to de-anesthesis on the occluded side. Just removing a thread, open the anastomosis, and confirming the lumen, and removing the coagulated clot. Okay, and flushing the blood flow, and check patency of the donor artery and the recipient artery. And you can visualize that both patency, donor artery is good, recipient is still flow here, okay? And you should try re-anastomosis at the site of the first anastomosis. And in that situation, you should trim the intima to visualize the intact intima. Okay. Small trimming on here, small trimming recipient artery, and small, very tiny trimming of the stoma, and you can see the intact intima inside the visceral wall. And once you confirm the intact intima, you can retry the trial for the anastomosis again at the same place of the first anastomosis.
Yeah, this is two situations. If we can fix it and we can make it a new anastomosis again. But in case if the receptor vessel is totally broke, there is a distance between the two sides.
Too short.
So it's too short.
Too short, yeah.
So we have to let's grant another new vessel at here. Then made the visual mouth side at here. So there is 3 anastomosis in the receptor vessel, right?
Yeah, of course. Yeah, you can try. So, this is 3 anastomosis. Yeah. In that situation, you just perform that. It's a good, good resolution for the occluded anastomosis. But very small recipient artery, maybe sometimes difficult, but it's okay to perform, just to try.
Okay, I see. Thank you so much.
We should try in that situation. Yeah, thank you for your comment. Yeah, I will try.
Thank you very much, Dr. Chen. Sorry to interrupt, but as usual, you've been very enthusiastic in interaction. Thank you very much for being there. I can see one hand raised. We'll take one last question and then we go to Professor Soichi Oya's lecture because he's been waiting there, and we can come back to the questions for Sensei Kimura. I will request him to be with us. The young lady neurosurgeon and young neurosurgeon are not going to let you go away so quickly. So I can see one hand raised, but I can't see the name. Could you ask your question, doctor? Yes, Claudia.
Good morning. Hi, good morning.
Good morning.
I have 2 questions, or maybe 3. The first question is there any condition that definitely exclude the possibility to do the bypass? I'm talking about any concern about age, comorbidities.
Comorbidity, the patient, the condition, do you mean the patient condition?
Yes, that may make you feel that is not a good candidate to do the bypass.
Thank you for your question. So severely disturbed patient is a patient suffering very consciousness is not good, disturbed unconsciousness, and hemiparesis is so severely disturbed. Complete hemiplegia is not good candidate for the bypass surgery. It's just our purpose is this surgery is to improve, not to improve, just to keep the patient settled, stable position, stable neurological status. So if the patient already suffered a severely impaired in neurological deficit, maybe sometimes this surgery is not good for the patient life. It's just harmful. But if the patient intends to receive the surgery to avoid the recurrence of the infarction, the patient desire to receive the surgery, even if the patient suffered the impaired neurological deficit. But in such a situation, I can of course perform the bypass surgery. But usually the patient is mild severe patient, mild hemiparesis. Of course, the patient should keep the consciousness awake. Of course, is a good candidate for the patient. Thank you.
Okay. The second question is, all of us have listened about using bypasses in when you are planning about a skull-based tumor resection. My question is, do you really believe that that effort really worthwhile to do a bypass before? I'm talking about if it's really important to do a complete resection, if you put it in balance, the risk of the complete resection, and if it really worth the effort going to do a bypass as well.
Yeah, you have a good point. So in the patient for the malignant tumor, skull-based tumor, and if the patient have a chance to radical removal or even in the malignant tumor, in such only in the situation we should perform the radical malignant tumor resection. After that, the bypass using a bypass and the revascularization should be needed. In the patient suffer the benign skull-based tumor, we don't need to touch the artery, just the tumor kept around the tumor. Yes, don't remove it around the tumor, even if the patient suffer the benign tumor. Yeah.
Okay. And the last question is, do you usually use papaverine to improve the flow during the procedure?
Yeah, usually I use a papaverine intraoperatively. Yeah.
Okay, that's all. Thanks.
The cottonoid salt. Yeah, thank you.
Thanks.
Thank you. Thank you very much for that wonderful discussion. I will put a hold into that and we'll have to move in with the next talk. May I request Dr. Ahmed Rashad Painda from Afghanistan to kindly introduce our next speaker, please. Dr. Ahmed. Dr. Ahmed, are you there?
Yes, I'm here. Could you hear me?
Yes. Yeah, please go ahead.
Yeah. I want to present my warm greetings to all today's webinar speakers, exclusively professors. And thank you very much, Professor Kimura, for the outstanding lecture. It's my great honor to introduce Professor Suchi Oya from Japan. He got his MD degree in 1998 from University of Tokyo, and currently he is professor of Department of Neurosurgery in Saitama Medical Center. His specialist interests are skull-based neurosurgery, brain tumors, vascular lesions, cerebral aneurysms, cerebral vascular reconstructions, endoscopy surgery, microvascular decompressions. And in today's webinar, he will be discussing surgery for meningioma. I kindly request the professor to start his discussion, and we'll be listening and benefiting from that. Thank you very much.
Right, thank you, Professor Parenda. I'm going to start my presentation. I'm going to share my screen. Just a minute, please. Okay, are you able to see my monitor?
Yes, Professor.
Okay, I'd like to thank Professor Yoko Kato and Sachin and all the members from SNS and the Young Neurosurgeon Society. And I'm happy for doctors from Afghanistan. You know, I know it's some sort of a difficult situation over there. The title of my talk is The Basics in Surgery for Meningioma. I will put an emphasis on how strictly we should follow the principle and how we can modify it if necessary. Through my talk, I like young neurosurgeons to understand the rationale of the principle. Also, in some difficult situations, I'd like you to learn how to change it to make situations better. So I think I'll be able to say my talk is going to be mainly for young neurosurgeons. I will explain the well-known principle, namely what we call 4D technique. I will show several cases from convexity meningiomas to skull-based meningiomas. Let me first explain the concept of meningioma resection. I always use this example when I teach my young residents about what's important for meningioma resection. Surgical resection of meningioma should not be a robbery. Instead, it should be more like a theft. We are required to remove the tumor by sneaking in and sneaking out without the landlord noticing it. What enables us to do this is 4D technique. 4D technique consists of these four well-known elements, which are devascularize, detach, debulk, and dissect. In most cases, the first two elements can be implemented at the same time. However, in more strict meaning, it's not always going to be like that. I will explain this later. Convexity meningioma is a good teaching material when young neurosurgeons learn surgery for meningiomas. First, you have to design the skin flap so that you can preserve the vascular supply to the free skin flap. These are the examples of a skin flap for convexity meningiomas. This slide shows the reason why we need tumor debulking. If you remove the tumor without debulking, the compression force created by your resecting maneuver might cause some brain damage on the other side. It's because the whole tumor will move as you touch the tumor, which may result in damaging the surrounding brain tissue. However, if you make the sufficient tumor, yeah? I think there's someone's microphone is on. Okay, let me continue.
I've muted it, so you can go ahead.
Okay.
Yeah.
All right. However, if you make the cavity, make the sufficient tumor cavity by debulking, the cavity will absorb the compression force, which will protect the brain on the other side. Let me explain this with this case. This is a left frontal parietal convexity meningioma. Now, after this dural sectioning, this whole convexity meningioma is devascularized completely. I'm using this case to clearly show the concept of the rationale of the 4D dissection. As you see here, when I move the tumor, this has nothing to do with the moving on this side. And now I'm removing the tumor and the debulking part was done. And I moved to the next step, which is the dissection of the tumor from the surface of the brain. And you know, nobody can prove how much important it is, but I try to preserve these small vascular network, including veins and of course arteries, to minimize the damage to the surface. As you may know, the convexity meningiomas carry high risk over a postoperative seizure. And I just try to, protect the brain surface as much as possible. And now these, we should, preserve these arteries. And if you have some bleeding, like a venous bleeding like this, do not coagulate this venous bleeding. You can stop this bleeding using the small hemostat. And just a gentle, you should gently compressed. And while irrigating this material, you will be able to obtain a good hemostasis. And then I continued removing the tumor. Because of the good debulking, I could, see directly on the back side of the tumor. And after confirming the hemostasis, I reconstructed the dura using the periosteal. And this is another important step. You need to take care of the tumor invading the skull, the flip side of the skull. You cautiously draw and you remove these tumor invading tissue from the flip side of the bone flap. And just to put the bone back. And the patient had an eventful postoperative course. And how about this middle fossa meningioma? First of all, please do not misinterpret this tumor as suphenoid or anterior crinoid meningioma. If you take a careful look at the attachment of the tumor, the bony change or the tumor portion invading the skull base, they will tell you where is the origin of this tumor. In this case, this is a middle fossa meningioma. To effectively devascularize this type of meningioma, you have to aggressively draw the temporal bone, which will eventually eradicate all the feeders. As a result, you will convert this skull-based meningioma into a convex meningioma. Now I'm drawing the temporal bone aggressively. And you see, this is the middle meningeal coming from the foramen spinosum. And to quickly, obtain the hemostasis, the guttering on the both sides of the middle meningeal is very effective. You can pinch this artery, formidable artery, by bipolar forceps easily. After the devascularizing and the convexizing was done, now it is easy for you to devascularize and detach the tumor because this tumor has now become a convex meningioma. And I incise the dura, a temporal base dura, as deeply as possible. And you see, this is the innermost part of the tumor. This is the ICA. And I use this part because I want to explain how to obtain a good hemostasis in a short time. You have to ask your assistants to hold the breathing from the right side of the operative field, and you concentrate on to control the left side. And then once you completed the left side hemostasis, then you move to the right side. This technique will, make the time for you to obtain the hemostasis shorter. And hopefully this tumor did not touch firmly the surface of the brainstem, the brain surface. So I could easily dissect, but I try to leave these small vessels because I'd like to, avoid the postoperative seizure. I'm not sure. I have no, scientific data if this procedure will prevent the postoperative seizure, but the postoperative seizure is a big issue for patients. And I also try to remove the tumor behind these, dura. That's the optic canal, and also I try to remove the tumor behind the tentorium, the free edge of the tentorium. Of course, this tumor is benign, the nature from the histological point of view. So you should not be too aggressive. The patient had a very good postoperative course, and the postoperative DWI, MR image showed no ischemic damage. Next, I'm going to talk about the tips for the FALCs on the parasagittal meningiomas. As for craniotomy, in my opinion, you should make the craniotomy large enough to expose this superior sagittal sinus. I know some might say, some might have different opinions. But I think that by opening widely, bipolar forceps don't hit the edge of the bone window, and you can expose important bridging veins sufficiently, which will increase the safety of surgery. Also, you should make use of the forks. You can cut the forks as much as possible because it normally has no function. So for Parasitic meningiomas, I will cut the forks above the tumor extensively to reduce bleeding. Then I will enter the tumor to the other side of the forks. Once I finish to hollow out the tumor from the forks, the tumor is usually devascularized. Let me show you one example. This is a parasagittal meningioma on the mainly on the right side, the parietal lobe. Now, this is actually an extremely hemorrhagic tumor. So I now try to section their forks as extensively as possible. I'm making like a 1 centimeter size margin from the attachment of the tumor. And I need more space to work for me to work, so I just enter the tumor, but I repetitively encountered a bleeding, arterial bleeding like this from the forks because I haven't finished the sectioning of the forks yet. But gradually, I was becoming, able to control the bleeding from the forks. And now I reached the other side of the forks and I completely detached the tumor. And still this tumor had some prior feeding from cortical arteries like this, as you see here. So I gradually making the space between the tumor and the brain surface. And the coagulation, sufficient coagulation will shrink the tumor. And then I could remove the tumor. These step-by-step eradication of the feeders are essential steps for better outcome like this. The patient had no deficit, and we achieved a near total removal. Actually, this turned out to be a SFT and HPC grade 2. Next, how about our anterior skull-based meningioma? How do you utilize 4D technique for these challenging tumors like this? In my opinion, the key is the arterial optic canal opening. With this strategy, you can eradicate feeders in the very early stage surgery before you actually start removing the tumor. You can also obtain the best visual outcome using this technique. While you need only simple surgical instruments, you do not need any fancy instruments such as specialized cruiser or cutting-edge navigation system. All you need to have is just a bipolar suction tubes and a high-speed drill. Let me show you a case. This is the left side, front temporal craniotomy, and look at this hypertrophied sphenoid bone. And you really need to do the flattening of anterior cranial base so that you can create the wide space, wide working space. And not only for creating wide working space, you are actually eradicating these feeders. You see the feeders around the superior orbital fissure. And this is the meningo-orbital band. As I cut the meningo-orbital band, I had some aggressive bleeding from the feeders. But you can easily, take care of these feeders. And also, again, I had a bleeding from the recurrent meningeal artery, which is functioning as a feeder. But you can easily stop the bleeding. And I don't see the point, the preoperative embolization for this type of tumor, because I can, take care of all the feeders during the skull base step. And again, to, obtain the hemostasis for this thick medial meningeal artery, I'm now guttering the on the both sides of the MMA and pinch the MMA using the for forceps. And after these parts are done, I opened the dura. And this is a space where I can work in, but I'm not, removing the tumor. First thing I'm going to do is to open the optic canal before I actually remove the tumor, because I'd like to confirm the location of the optic nerve and the ICA. Because even for this huge tumor, the location of the optic canal has not changed. So I can open the optic nerve, I can open optic canal. And as you see here, there is no bleeding from the tumor. And next, I will explain the part of the tumor resection. And for safe tumor resection, I think you need to create a bloodless field like this. So you've already done with the skull base part, and you achieve the hemostasis through the feeders. So there is little bleeding from the tumor. This is the M2 portion, but you can see all the feeders, perforators very clearly. And sometimes there is a firm adhesion between the tumor and the M3 portion. But thanks to the bloodless field, you can see very clearly the interface between the tumor and the brain. And another important, the technique is the dissection using the suction tube like this. And this is the feeder from the cortical ACA. And this is the final step. And I remove the tumor. This is not always necessary, but I confirmed the patency using the ICG video angiography. And the patient had a very good outcome. However, he had, I don't know why, but he had a rachial infarction on the contralateral side. But all the tumor was removed and he returned to his normal life. But you should be aware that some feeders are really formidable to approach. One example is the anterior choroidal artery for lateral ventricular meningioma. As you see here, the feeding artery are developed from the anterior choroidal artery. But if you use the high parietal approach for this tumor, you will see the feeder at the very end of resection. Previously, I have used the transmiddle temporal gyrus approach, making the small corticotomy to get in the lateral horn of the lateral ventricle and apply the clip at the feeders from the anterior choroidal artery. Then I approached the tumor via the high parietal approach. We have used this strategy for 2 patients, but both patients had frequent seizure after surgery, which was medically refractory. So we just gave up this strategy. So I think the anterior choroidal artery for this type of tumor, they are very challenging. And also ICA, meningohypophyseal trunk feeders for paracranoid and the temporal meningiomas. These are also difficult to take care of. This is a posterior crinoid meningioma, and this tumor had 2 significant feeders from the inferior lateral trunk of the ICA, and meningohypophyseal trunk from the ICA. So we decided to utilize the preoperative embolization for this patient, but as a result, he had a right side complete oculomotor nerve paralysis. And thanks to the embolization, as you see here, the tumor was almost completely devascularized. However, the cranial nerve deficits from the ischemia, it's not, it has little hope to recover. And the patient his vision returned to almost a normal level, but he continued to have the cranial nerve paralysis of the third nerve. And thirdly, the existence of copious pyrophyters are well-known risk factors in meningioma surgery. The risk of preoperative embolization of pyrophyters is significantly high, as I presented, and its role has not, its role has not been proved. So you yourself have to fight these pyrophyters. I'd like to introduce an example of our trouble in relation to hypervascular meningioma. Preoperative angiography showed well-developed pyrophyters, as shown here. In addition, there was a remarkable AV shunt. As you see here, this is the AV shunt and the dilated cortical vein here. And we thought we could take care of feeders from the ECA during the craniotomy, and that the risk of preoperative embolization is high. So we just decided to resect this tumor without preoperative embolization. But as you see here, I had the trouble in controlling the bleeding from the tumor. Every time you cut in the tumor, I encountered a copious amount of the bleeding from the tumor. However, I tried my best to control this bleeding. I was patient at this time, and I tried to remove the tumor in a piece-by-piece fashion like this, removing the tumor. And this is about 5 p.m., like 8 hours have passed since I started the surgery, and I could finally create the space in the extradural space, and I could achieve the devascularize. However, I accidentally injured the drainer like this. I tried to obtain the hemostasis using the hemostat, but after this, accident, the tumor suddenly enlarged, and I had a bleeding from anywhere of the surface of the tumor. So I need to use the finger dissection. I felt the MCA, and I just tried to leave the MCA, but I had a bleeding like this, and I control the bleeding from using the gauge and using the aneurysm clips. And the surgery was finished. But I was lucky because this was on the right side, and he had no deficit, although he required blood transfusion because he lost 7,000 milliliter blood during surgery. But the ischemic complication, ischemic infarction was limited to the right frontal lobe, so he was completely fine. Soon after this case, we encountered another hypervascular meningioma. This is a left convexity meningioma with significant edema. This tumor also had well-developed pyrophyters like this. I knew that I had to do something different to avoid the vascular complications as we experienced in the previous case. This is especially important because this tumor was located on the left side. Then I found this paper from India. This paper introduced unbroke resection, unbroke excision as an option for some selected large vascular meningiomas. I like the concept of this report because we do not need any fancy surgical instruments or preoperative embolization by endovascular expert. So I think this is beautifully simple. So we use this technique for this case. Now I'm cutting the MMA, and I created a small hole, dural incision, just right onto the tumor. And I did not permit any small amount of bleeding. I try to control all these small amount of bleeding by aggressive coagulation using the bipolar forceps. And I gradually, expand this dural window. I'm still on the, the tumor itself. And I try to, coagulate the, the margin of the tumor. And I gradually exposed the brain. But, the brain itself is covered with the dura, which is now working as a natural, brain retractor, protector. So by doing this, there is only one single point where it bleeds. So I could easily, control the bleeding. Sometimes I found the feeder like this, feeding from the cortical artery. As you see here, there's bleeding. But this is the only place where I am having the bleeding, so I could easily control the bleeding and coagulate the feeder. And then I expanded the dura again. And I try not to, this is important, but I try not to, open the cistern. And I try not to drain the CSF. By doing this, with the increased intracranial pressure, the brain itself is compressing the tumor towards the outside of the dura. So I could remove the tumor like this in an unblocked fashion, and just added some brain, dural sectioning to achieve the Simpson grade 1 resection. The patient had no ischemic complication, and he did not need a blood transfusion. So this is my last slides. Today, I covered these topics. I had hoped to convey the messages shown here through my presentation. Needless to say, it is important to learn and follow the basics of meningioma resection from a theoretical and a technical standpoints. You will gradually be able to modify it for better outcome when you can understand the rationale of these basics. I believe in surgery for most meningiomas, knowledge and strategy is more important than instruments. Thank you for your attention, and I'm happy to have questions from you. Thank you.
Thank you very much, Professor Soichioya. It's difficult to cover all the aspects of different kind of meningioma in one lecture, but you have very briefly summarized, and that was an very lecture for all the young neurosurgeons. I am sure definitely there'll be many questions. Yes, you can see hand raised by Dr. Ben from Hong Kong. Dr. Ben, please go ahead. Kindly introduce yourself and ask your question.
Yeah, hello. I'm a Ben from Hong Kong, and thank you for your presentation. It's very good for a young neurosurgeon for the basic meningioma principle. For my question, first of all, I also ask because sometimes I encounter those atypical meningioma. The plane between the tumor and the brain is actually not well defined. So how would you deal with that, and how would you try to leave a small piece of a so-called tumor capsule behind to protect the brain, or you try to dissect it out? And also for those, another question is for those pile feeders. Like when would you try to tackle those pile feeders? Is it at the dissection phase of after coagulation of those ECA supplies, or at the very initial phase of your tumor dissection? That's my question.
Okay. Thank you for asking. Yeah, that's a very nice questions. For your first question, I think it depends. It's not easy to generalize. How aggressively we can become, and we need to take these factors into consideration when we set up our strategy, like our patient's age, comorbidities, and if the tumor is in the eloquent area or not. So, for example, if it's young patient with huge tumor, but the tumor location is non-eloquent area, I will probably enter the brain, and I will, I don't care about the disrupting the pia mater, and I will try to remove as much as possible. Especially when I was aware that the tumor is going to be a grade WHO grade 2 meningioma. But if the patient is advanced stage, and if it's near like a motor area or something like that, I will choose to leave tumor capsule. I will not to dissect the tumor from the brain, aiming for treating the tumor using radiation, post-operative radiation. And for your second question, also it depends on the situation, like how much bleeding we are expecting, and the location of the tumor. But basically, we need to first, even for tumors with copious pyrophytes, I think our first step we have to do is to stop the feeder, cut the feeder from the ECA. So we have to detach the tumor from the dura to reduce the feeding, to reduce the bleeding from the tumor while we are debulking. And then I will carefully, check the how amenable the tumors are for me to dissect. And again, if I can enter the the brain parenchyma without hesitation, after considering all the factors, well, I will enter the pia mater, and I will remove the tumor with a small, normal brain tissue. I will not hesitate. But if I thought it's not possible, to tell the truth, I have made some worse, the bad scenario, bad outcome, because I think now I was too heroic at the time. To remove, I tried to remove the tumor because even though the tumor was very hemorrhagic, and the patient had a very bad outcome. So the meningioma, it can be histologically benign, even if it's extremely hemorrhagic, but still it can be benign from the histological standpoint. So we should not be too heroic or too aggressive from the first surgery. That's my opinion.
How about like for those, if you could achieve a gross total resection of the atypical meningioma or malignant meningioma, would you consider upfront SRS in your center for those, even with a gross total resection, or you wait for the recurrent?
Okay. You're talking about the upfront or adjuvant radiation after gross total resection of the atypical meningioma. That's been the target of the research, from the big registry from the European countries and North America. And they, based on, according to the data, there is some advantageous, beneficial effect in adjuvant radiation immediately after surgery, even for gross, even after gross total resection. However, that being said, but I'm kind of hesitant to use the adjuvant radiation for patients who had a gross order resection. Possibly, apart from the grade 3 meningiomas, for grade 2 meningiomas, I will hold the adjuvant radiation. I will not do it right after surgery.
Right. Thank you so much. That was a really nice presentation.
Thank you very much. You're welcome.
Thank you very much, Dr. Ben, for very nice interaction. I can see one more hand raised. Dr. Nujer, can you ask your question?
Yes, thank you, Professor Oya, for a wonderful lecture. I have a question. So when we have no typical meningioma like grade 2 or grade 3, and the bone is infiltrated, so sometimes we can drill the bone. But I read in a paper that it's not better to make a drilling. So it's better just to discharge the bone and make a cranioplasty or do a second surgery. So what's your experience or your opinion about this topic?
Are you afraid that you might be dispersing the tumor cells?
Yes.
Okay, that might increase the risk of, dissemination or metastasis. Are you talking about that? The risk of dissemination using?
Yes, after surgery.
After the skull base, after the skull base during?
Yes.
Okay, well, I personally have no experience like that. So in my opinion, I will do aggressive drilling even for grade 2 or grade 3 meningiomas. But, there are many large retrospective studies have shown that the Simpson grading system has no meaning in grade 2 or grade 3 meningiomas. So, which means how aggressive we are cannot change the result. So in that case, in that scenario, I think that we have to put our priority on the patient's outcome, I mean, functional outcome, instead of the extent of resection. But skull-based drilling, if it's safe, I think we should do that. That's my opinion.
Thank you, Professor. And the other question is about the opening the dura. So when I was getting training in Latin America, we usually open like big dura. So we expose all the brain. So then when I came to Japan to do the fellowship, so now here we don't open the dura completely, we just get to the point where the tumor is. So both ways I think are very useful. So what is your opinion about, you prefer to open all the dura so you can see all the tumor around, or you prefer just to go straight where the tumor is and make the incision through the dura to the tumor?
Okay. In the final situation, I think we need to resect the dura as widely as possible. But for example, like one case I showed today, if it's the huge, the big, kind of large hemorrhagic, convex meningioma, I will try to restrict the size of the dura at the first part of the surgery to protect the brain around the tumor. If I cut the dura widely for that case, I think that will make the brain tissue around the tumor contagious, like under contusion, because the tumor is large and high pressure, high intracranial pressure, and the tumor has a lot of pyrofeeders. So I try to, in that case, I restricted the opening of the dura, and gradually I was making the boundary between the tumor and the brain, so that I could control the situation.
Thank you.
Do I make sense?
Yeah, totally.
Okay.
Thank you very much, Dr. Nujerling. You can see one more hand raised. Claudia.
Okay, my question is about the anterior skull base case. I didn't see if the doctor did anterior clinoidectomy. My question is, do you think all of those cases it is possible to do anterior clinoidectomy? Because I saw that the tumor in that case was really, really big, and maybe it was not possible to do a secure or a safe brain retraction to do the anterior extradural clinoidectomy. That's my question.
Okay, thank you. That's another good point. Actually, I did an anterior craniodectomy in that case, but I didn't show that in my video. As many people think that anterior craniodectomy is risky for huge tumor because you have to retract the brain under the increased brain pressure. However, in those cases, almost all the patients have a very hypertrophied sphenoid bone. So you have to make use of the hypertrophied sphenoid bone by drilling the sphenoid bone. You can create the enough space for you to draw the anterior cranial process. So instead of retracting the brain, just you aggressively drill the sphenoid bone, and well, I have no trouble in removing the anterior cranial process, even for huge anterior crinoid or anterior skull base meningiomas. But it's not easy even for me to explain this. But maybe if I had a next chance, I will show you how I can do it. But you need some experience or to understand what I'm meaning. Okay.
Okay. Yes, that's why my question was done, because 2 days ago I had a case where I was not able to achieve the anterior clinoidectomy.
Okay.
I feel quite frustrated. But then I didn't know it was my fault because I was not able, or because it was really, really difficult. I had done some cases before, but in tumors that was little anterior clinoid tumors, but this case was big, and I feel that even when I tried to go back enough, I couldn't achieve. I couldn't feel the anterior clinoid when I was touching. When I was afraid to keep going because I felt that I was really, really back.
Well, actually, I just remember that only one case in which I couldn't remove the anterior cranial process. The anterior cranial process was too thick at the time in the case, so I just gave up. And that's not the point. The point of my talk is to open the optic canal and confirm the location of the optic nerve and the ICA first, before you actually remove the tumor. That will increase dramatically the safety of the removing the tumor. So even if you leave the anterior cranial process, but you can take care of it later. After you remove the tumor and you decrease the intracranial pressure, then you can, check the anterior cranial process from the intra or extra dural space.
Okay.
Okay.
At the end of the procedure.
Right.
Okay. Okay. Thanks.
Hello, Professor. I would like, I just heard the interaction between you and Claudia. I would like to echo over that. A few days ago, I did a choroidal meningioma, and for the drilling of the anterior crinoid process, would you routinely divide the meningorbital band and also peel peeling of the middle fossa dura in the early phase to expose the anterior canal? Because for that moment, I did these steps so that the clinoid could be exposed easily. And sometimes the other clinoids there was some hyperostosis due to the meningioma, so that the clinoid would become very thick, and also the panel will become very thick. So would you do this in every cases to unlock the anterior clinoid process early during position?
Yeah, actually, sectioning of the meningoorbital band, I always do that, because without that, I could not expose the superior orbital fissure. But I know also, I'm aware that most people, enter the intradural space to open the lateral cavernous sinus and to retract the temporal dura backward. And I don't do that.
Okay.
And that's not necessary.
Okay, I see. Thank you.
Thank you. Thank you very much, Dr. Ben. There are no questions. May I ask Professor Firzad Tawad to please make few comments about Sensei Kimura and Sensei Oya's talk, please.
Thank you very much. Arigato gozaimasu, Professor Kimura and Professor Oya, Sachi. Thank you very much for nice presentation. It was very good and useful, and it was stepwise. It's good for young neurosurgeon. That's for the education and learning field. I think it's very useful, and it was good for beginners, and also for us. It's good for. Thank you for sharing your experience, and also for your points you mentioned. And it was good step by step. And as you mentioned, we have also difficulties, but bleeding during operation, and also in Afghanistan, we are experienced with trauma or neurotraumatology, but also we have a lot of cases of brain tumors, and which tumors that we have. Sometimes we are faced with bleeding. It's difficulties, and we feel this one, and also about edema. We have some difficulties during the operation, but fortunately our results are good for the brain tumors operation, especially meningioma, and the points you mentioned, we take note, and also we discuss with our young colleagues that they are not able to hear. Thank you very much, and also thank you for Professor Kimura, and that's he mentioned about it's a controversial issue of EC, IC, anastomosis, but it's good. And in our country, in Afghanistan, we have one option for the treatment of ischemic stroke, and it's conservative treatments, because we haven't no TPA, no thrombectomy, no endovascular surgery, and no surgery for anastomosis. And you mentioned Professor Kimura. It was good. That's open our colleagues' mind about that. This another options for the treatment of ischemic stroke, and it was useful. Thank you very much. Arigato gozaimasu. Shukran. And thank you, Gracia, for Niger link, and shukran for Nadia for nice comments. Thank you very much.
Thank you, Professor Firzad. As I said, in spite of working in those low resource condition, the kind of courage and the kind of happiness you carry and work with, that is seriously miraculous. So thank you very much for your wonderful comments. With that, we've come to the last talk of the session. And may I request Dr. Nadia to please kindly introduce Dr. Rihanna and her topic of presentation. Dr. Nadia, are you there?
Yes, I'm here. Should I share my?
No, you
screen?
can. I've already shared. You can just
okay.
Speak. Yeah.
Wait. Okay, Dr. Rihanna Ghaffari. She's a young nurse resident of neurosurgery from Afghanistan, from Al Teaching Hospital. Today, she's going to present us a case of managing intracranial tumors in pregnancy. And now I'm going to present her today. Please, doctor.
Hello, Assalamu alaikum. Good afternoon to everyone. And thank you so much to Professor Acns and Afghan Neurosurgical Society for this opportunity. Can I share my screen?
Yes, Rihanna, please share your screen.
Can you see my screen?
Just rolling, just a moment. Yeah, it's visible. Please go ahead.
Okay. Bismillah ar-Rahman ar-Rahim. Today, my presentation is about managing intracranial tumors in pregnancy. I'll first present my case, then I'd like to discuss about the challenges that we face in management of these types of tumors in pregnant ladies. We had a patient, 22-year-old female patient who was referred to our neurosurgical department of Aliabad Hospital by her ophthalmologist with complaints of progressive vision loss for 20 days and also headache. On initial examination, her Glasgow Coma scale was 15. Her pupils were reactive and she had some vision on her left eye, and on her right eye, she had no light perception. On fundoscopic examination, she had papilloedema, and also she was 5 months pregnant with her second child. Her laboratory exams were within normal limits, and also she had a history of COVID-19. This is the imaging that she had with her on the time of admission. She had an MRI done before coming to our hospital. As we can see, we see a mass on her left occipitoparietal region. After consultations were done with doctors of anesthesia and internal medicine, and also her OBGYN, she was admitted and she was operated upon. The operation was done under local anesthesia and done with hand drill with a left parieto-occipital craniectomy was done. The tumor resection, complete tumor resection was achieved, and also her baby tolerated the operation very well. During surgery and also on post-operative period, fetal movement and also fetal heart rate was monitored by OBGYN doctors, and it was normal. She had an uneventful post-operative period. She was discharged on her 6th day post-operative with good condition and referred to her OBGYN. On discharge, she had vision on both of her eyes. This is a picture of her tumor that was resected. On her next visit was on 8th day post-operative, and both mother and the fetus were doing fine. She had some pus-like discharge from her incisional wound, and clean dressing was applied, and she was discharged to home. This is a picture during the surgery of the patient. The surgery was done by Professor Pirzat. And also you can see my colleagues and me. Unfortunately, we lack of the patient with the conditions here being really stable, so we did not receive her pathologic report. But now I would like to and a little bit about the challenges that we face in management of intracranial tumors in pregnant patients. There is no accurate statistics for prevalence of intracranial tumors in pregnant women. And there's also no statistical association of brain tumors with either head trauma or with pregnancy. In women, most common brain tumors that are there is pituitary, in this order with is pituitary tumors, meningiomas, gliomas, and metastases of breast cancer, carcinomas. But in pregnancy, we see meningiomas are very common. They are twice as high in women, and also intraspinal meningiomas are 7 times higher in women than in men. This is because sex hormones accelerate the growth of tumors, especially during the later phase of menstruation and also during pregnancy. In researches that has been done, they have seen progesterone, androgen, and also low levels of estrogen receptors on meningiomas. Now, the problems that we face in management of intracranial space occupying lesions in pregnant women, one of the main problems is in diagnosis, because symptoms of brain tumors like headache, nausea, vomiting are similar to early symptoms of pregnancy, and also similar to symptoms of pregnancy-related complications like eclampsia or preeclampsia. That's why they are not diagnosed initially. And also using use of neuroimaging like CT scan in a little bit contrast enhanced MRI should be avoided, especially in first trimester. MRI is the study of choice for pregnant women, and we cannot use contrast agents like gadolinium in pregnancy. That's why diagnosis is a little bit difficult. The second problem that we face is problems in treatment. One of the main cause of signs and symptoms in these patients are cerebral edema and also increased ICP. We cannot use the glucocorticoids have been used in pregnant women. However, if we use them in long-term steroid usage, can cause fetal adrenal suppression, which mandates the use of supplemental steroids in prepartum period in these patients. And research have shown that mannitol does cross the placenta and excreted by fetal kidneys, but no adverse effect of mannitol has been found in these patients. We come to the anesthetic management of these patients. They say that pregnant patients are at increased risk of aspiration during general anesthesia and during surgery, and also after surgery. The fetal heart rate should be monitored if it is possible. Choice of anesthesia depends on the maternal condition and also maternal indications. But they say when possible, use local or regional anesthesia. On postoperative management, the patient and also the fetus should be monitored. Fetal heart rate and uterine activity should be monitored. Adequate analgesia should be given, and also to prevent deep vein thrombosis, the prophylaxis for that should be given to the patients. Outcome of these patients, frequency of each brain tumor type appear to be similar for pregnant women and also for non-pregnant women. There is no association between tumor grade or the likelihood of recurrence, but the extent of original tumor resection corresponds with recurrence risk, also its progression. Nearly half patients with grade 2 or 3 glial tumors have become pregnant after diagnosis, experience disease progression during or immediately after the pregnancy. The decision whether to proceed with vaginal delivery or C-section in patients who have brain tumor is influenced by the tumor burden. Also, we cannot assume that the growth rate is accelerated by high rate of tumor progression, and malignant transformation has been seen during pregnancy. Survival rate in these women are similar to survival rate in women who are not pregnant, but the worst survival rate has seen in GBMs, that is about 4.6 years in these patients. Also, unfortunately, in the past 6 to 1 year, we have seen an increase in the intracranial tumors patient, especially in our hospital. About 60 to 70% of our hospitalized patients our hospital are intracranial tumor patients. A reason for that, but we have seen a significant increase in, especially nowadays. These are my references that I used. Thank you so much for your listening to my presentation, and if you have any questions for me.
Thank you very much, Dr. Rihanna. I must congratulate you and thank you very much for bringing that case up for discussion, because I'm sure in the life of each and every neurosurgeon, you will have a situation where you'll have to manage a pregnant female with some sort of neurological problem. And I must tell you, your English is very good. So congratulations for that. And without any doubt, I think I would go to Professor Soichi Oya and Sensei Kimura with the debate of discussion. She's already mentioned the point of debate, but just to summarize them, in case of pregnant female, whether which is the best trimester to operate, first, second, or third, what is the best sort of anesthesia, whether it's a general anesthesia or local anesthesia, and what sort of surgical strategies, whether they differ from the normal surgery or as compared to pregnant lady, and about the outcomes. So anybody can take first. Sensei Soichi.
Okay, thank you, Laihana. Seriously, I'm not sure that if I can do the same thing, you know. So I really congratulate on your good success, you know, the success of in this case. You saved 2 lives. Well, my question is going to be about the local anesthesia. You know, you perform the craniotomy and removing the tumor under the local anesthesia. I've never, you know, except for awake surgery for gliomas, I've never experienced, especially for pregnant women. Did you encounter any trouble to, you know, like control the vitals or like, yeah, did you encounter any trouble during the surgery?
Thank you so much, Professor. For this patient, fortunately, we did not encounter any problems with her or her child's vital sign during surgery under local anesthesia. She also received some pre-medication to just calm her down and not to get her heart rate too high. But the surgery was done under local anesthesia, and with this patient, we did not face any problems.
That's great. I might have missed, but haven't you gotten any pathological result? Was was it a meningioma or was it some sort of a gliomas?
No. We did not receive her pathology report because we lost track of the patient. With this condition here, they are not good, so people are fleeing every day. But we did not receive her pathologic report, but her MRI report did not specifically say meningioma. Also, it was not meningioma.
I see. Thank you.
Thank you. Thanks so much.
Thank you very much. Sensei Kimura, you want to make any comments?
Yeah, thank you, Dr. Laihara. Yeah, good presentation, nice presentation. I have enjoyed a lot. So yeah, so during pregnancy, the patient has a tumor. Great. Sometimes I'm working at the university hospital, so I have sometimes encountered that some kind of patient. So I remember one patient suffering she complained numbness by lateral upper extremities, and during the about 7th or 8th month pregnancy. So at the time she received a scan, MRI scan, so demonstrated C1 level neuroma compressing the spinal cord. So markedly. So just maybe I explained to the patient. So during the pregnancy, the operation may be so difficult to and sometimes hazardous to the infant. So to avoid the reason why you experience the numbness, during the pregnancy, the body weight and the body water balance is increased compared to the normal life. So after the pregnancy, maybe the numbness may be decreased after the child born. So just wait for the operation. So because the tumor is located on the C1, C2 junction, a C1 level, so the surgeries may be more complex, needed more time, of course, under the general anesthesia. So in that kind of situation, I hesitate to perform the surgery. After the child born, I will operate the patient is tumor removal. Maybe up to the patient's symptom, we need to choose the surgery during the pregnancy or not. Symptom is very important, of course. So up to the patient's condition. Yeah. Yes. Thank you for your nice presentation.
Thank you so much.
Yeah, thank you.
Thank you. May I ask Professor Pirza to make few comments because he's operated on this patient and maybe he's some personal expert comment about handling of this case. Could you please say something, Professor?
Okay, thank you very much. Thank you, Dr. Rayhana Ghaffari, for a nice presentation. Be proud of you, and thank you for Professor Kimura and Professor Suchi Oya for nice comments. And it was very difficult, that I mentioned before, that for the even in diagnosis and also in the treatment in low resource country and centers like Afghanistan, it's very difficult. And as you know, we have patients with no chance for going abroad, and with neurological deficit become deteriorate and progress. For this reason, we must operate. And for this lady also, that's as Dr. Rayhana mentioned, she progressively lost her vision, and for this reason we operated on her, and fortunately it was the result was good, and we saved her and her child and her baby. And we are faced with difficulties for diagnosis, and also, as you know, in Afghanistan we haven't neuronavigation, and we just use ultrasound during operation for the locating the tumor, and for also for hemostasis. and for take care and management of patient during operations. Sometimes we have difficulties, and we unfortunately use old anesthesia machines, and for this also sometimes we face some power difficulties. For this reason, sometimes we prefer for local anesthesia, and patients tolerate it. And as you know, that's the weak operation that's good, and we use this in our center, and we have a lot of brain tumors operated, and the result was good. And for which tumors like meningioma, that's convexity surface, it's easy to operate in Afghanistan in a situation like us. And thank you very much for the chance and also support Afghanistan. As Dr. Rayhana mentioned, still we use hot sand drill. Thank you for Professor Katu, and also WFNS Foundation and Afghan American community, especially Professor Ali Aziz Sultan, that's they prepare and donating high-speed drills, and we hear that they deliver to Kabul airports, and soon as possible we will have drills in our hospitals, not in Kabul, but also in provinces. It was a good news, and thank you for supporting. It was your initiative, especially Professor Kato and Professor Sachin, that's you make the this way to support Afghanistan people through neurosurgery supporting. Thank you very much. Arigatou gozaimasu, and gracias for you. Thank you.
Thank you very much, Professor Pizat. We are glad that with the efforts of everybody, the situation of neurosurgery and neurosurgery infrastructure in Afghanistan is improving, and we congratulate you for that. But make sure that these high-speed drills and high-end technologies are very, very delicate, and they should be handled by the expert person only, because the maintenance is very big problem. I mean, in Afghanistan, maintenance of high-speed drill, if it goes malfunction, it will be very, very difficult. So make sure that trained person only handles those high-speed drills.
Yes,
Dr.
yes.
Javid
Okay,
is also
thank you.
there
Yes.
from.
Yes, yes.
Yes, yes.
Yes, thank
Dr.
you very much.
Javid is also there.
Also, yeah.
Yes, yes, please go ahead, Professor.
Yes, we and Dr. Javed and Dr. Aziz Sultan, we have Afghanistan initiative support, and we discuss on it. That's the donation is good, but the maintenance also is important. And we ask for a biomedical engineering, that's they trains the biomedical engineering to take care of this instrument in Afghanistan. And also Dr. Javed have a lot of support for Afghanistan neurosurgery. We thank you and say greeting for also for Dr. Javed and our colleagues outside Afghanistan. Thank you very much.
Thank you very much. Dr. Javed, you want to say anything?
Thank you, Session. Thank you very much. Thank you to Prof. Pirzad, and congratulate Dr. Rayhan. Actually, amazingly presented. Very well cased. I was amazed. I know the way the handling such a complex cases. Like it's really I'm involving with Afghanistan for the past basically almost like 2-3 months. I'm involving with Afghanistan, and I know how much limitation and difficulties there. Like to operating the case in such a complex case like this kind of this gliomas with pregnant woman, I mean, even in very hi-fi centers, I think it will be challenging to operate it. So I really congratulate them. And we work with them, so with Afghans, colleagues and institution very closely. And from this initiative, I thank Professor Kato as well to put and encourage all the Afghan societies. So I think right now we're going on the right directions at this point of time. I just have to have one or two comments on this case. It was a very interesting case to see if you're handling this kind of case. Looking from the scan of this one and the gross pathology of this case, to me, it doesn't look like it's looking like much more look like a gliomas. But for young surgeons who are sitting here, if someone is coming with the females and have a mass there, I think another thing is should not miss the metastasis. You have to screen the patient. You have to look for the breast and all the other things to make sure it's not metastasis. And it's better to if you follow up the patient. I mean, Afghanistan situation is different. If the patients come, if it's a low-grade glioma, I think it's better to follow up to probably and you send it to the center that they can get further more treatment. But it was a really good case. Thank you, Dr. Rayhana. It was a good case. Thank you.
Dr. Pizza, do you want to make any comments?
Yeah, thank you very much, Dr. for nice comments. We agree with you, and as you mentioned in Afghanistan, that unfortunately that patients become better than we can follow up the patients, and they going to the provinces and didn't come back to hospital. Even some complication start, they come back to for follow-up. Otherwise, they escape. It's unfortunately this in Afghanistan. It's not good, and we agree with you for the metastasis and for diagnosis with low resources. It was sometimes it's difficult, not good in Afghanistan. Also, the other things I like to mention about the radiotherapy. And unfortunately, not in this case, but in other cases for radiotherapy or for chemotherapy, unfortunately, we haven't access for radiotherapy for brain tumor, which are sensitive to radiation, not in this case, in other cases. And as you know, before the war, we have radiotherapy access in Afghanistan. We have professors, Professor Abdurrahman Salim and also Professor Malik Asghar. They did 40 years ago radiotherapy in Afghanistan, and also we had oncology center. But unfortunately, during the war, we lost all of them, and we hope that's also you will take care, all of our colleagues supporting Afghanistan, about supporting for maintenance and also for radiotherapy and chemotherapy for Afghanistan people. Thank you very much. Thank you, Professor Javed. Thank you very much.
Thank you. Thank you very much, Professor Pizzar. Is there any question or any comment anybody wants to make? Yes, Dr. Chen, can you make a quick comment or question, please? You have to unmute yourself. You are not audible, Dr. Chen. You have to unmute yourself.
I'm unmuted. Yeah. Thank you, Rehana. I'm happy to see you again, and you're doing a well job, and you are very. I'm proud of you. You are very brave to take this challenge. This is very challenging, because this is a pregnancy woman, female patient. My question is, do you have any trouble when you communicate with patient's family before operation? You have to explain the risk of the surgery. In case of their family cannot accept the risk, it's very trouble. So do you have some communication barrier with the family?
Thank you. Thank you.
Yeah.
Dr. Chen, thank you so much for your support always. We do have problems with communications of consent discussed with this patient, and also her husband did not agree, and because of her precision was not wait any longer for the surgery to wait till she delivers the baby. That's why it was we operated during her pregnancy, but we do have challenges regarding the communications with patient's family, not only her husband, but also her extended family. So yeah, thank you.
Yeah, and with your vision, the tumor tissue looks like a glioma or meningioma. Can you differentiate them? Looks like a glioma, low-grade glioma, because you have no pathology result. Yeah.
Yes. Discussed with patient's relatives and husband. If the pathology reports come back of some malignancy, or if it is glioma, then she will need chemotherapy or radiation. For that, you have to take her out of the country. But before surgery, they said they agreed, okay, we will, but after surgery, lost track of the patient. She did not come for her next exams, and they did not bring her pathology report, so that we couldn't say anything.
Okay, so in the future, when you have the pathology result and when the baby delivered, this female patient need radiotherapy and chemotherapy. So I think the follow-up after operation is very, very seriously. Okay, that's all my comment and my thought. Thank you so much, dear.
Thank you.
Thank you.
Thank you very much. Dr. Pirzad, you have a hand raised. You want to say anything?
Yeah, thank you, Dr. Chen, for nice comment. Yeah, it's difficult also for Afghanistan. Another thing that's the histopathologic examination, and we send the histopathology for the histopathology department of Kabul University of Medical Sciences. We have professors down here, but they charge on examination, and the hospital haven't any fund to pay the charge, and patient relation must pay the charge. For this reason, we send the biopsy through the patient relation. For this reason, sometimes patient relations didn't pay money for the biopsy. They think this operation is over and no need for biopsy. Even we explained all the things, but sometimes they skipped and or didn't bring the results back. Not in this case, in other cases also. This is also a challenge, and we like to have some ways to find some solution for this, also to support the examination histopathologic department for us. But for this reason, sometimes that our people are poor and they haven't to pay money to pay this. There is no insurance in Afghanistan, health insurance yet, and this is also another challenge in Afghanistan. Thank you.
Thank you, Dr. Pirzad. I understand. Maybe after the COVID situation goes down, we can discuss about some short-term neuropathology fellowship for the pathologist in Afghanistan. I think that can be done, but COVID is the biggest challenge. Traveling is still restricted. That is the problem. So I think we have come to the end of our webinar. We had a good webinar today. First talk by Sensei Kimura Hidehito. I must thank him again with the core of my heart that on the 11th hour he accepted my request and came for an presentation. He gave one of the exemplary presentation with those beautiful cartoons and the basic techniques of bypass as a virtual demonstration. And another talk by one of my friend, Professor Soichi Oya. I think he gave a very realistic talk, because most of the people will come up and show their good cases only. Nobody shows the bad cases. And he showed us one of the two cases which he showed us, the one with the 700 ml blood loss and the one where the embolization caused third nerve palsy. I think the message is we should learn from each other's mistakes. So thank you very much for bringing up the realistic and very good presentation. And Dr. Rihanna, I'm very glad you brought up this. This is very, very good moment. A pregnant female having a baby and a female neurosurgeon who was a part of the surgical team coming up and presenting this on a good platform. I must congratulate you for that. And I thank all the moderators, Dr. Nujerling, Dr. Nadia, Dr. Chen, Dr. Claudia, and Dr. Ahmed for active participation. It was a good show. I would request Professor Yoko Kato to say a few final remarks about the webinar. Thank you, Professor.
Thank you very much. So nothing to say after the Sachin said everything. So, but I think Professor Oya and also Professor Kimura are representative of Japanese, the Neurosurgical Society, the future, the very expecting the professors, I think. So that you are very lucky to listen to their lectures today, I think. Both of them that show us very basic things to the higher advanced cases. So you may have maybe a lot of questions, but maybe you can discuss by email, I think. And also the Afghanistan, Professor Pirzad, thank you very much for joining every time. I know the association, maybe hopefully we should support not only the technical things, but also the infrastructure. That is most important things for you right now, I think. So anyway, then we should continue our awareness committee, such kind of webinar education in the future. Thank you very much for all attendance. Thank you.
Thank you. Thank you very much, Professor. Yes, Chen, you want to say something?
I'm thinking, I have a suggestion. If Rihanna or her hospital can send the perforating pathology slides to Japan for pathology exam, could she do this? Email to the international email to Japan for the pathology diagnosis for the pregnancy case.
Well, I think I can help a bit, and if she or Professor Polani send me an email, I have a good colleague of our pathological department, and I will ask them, and they will definitely help you.
Okay, great.
Thank you. So
yeah.
That's a very good generosity by both Dr. Chen and Dr. Soichi Oya. So Dr. Pirzad, if you have made the slides, you can send the slides or the photographs of the slides taken by microscope to Dr. Soichi Oya or to Dr. Chen, and they will try to help you with the pathology of the patient.
Okay, thank you very much. Thank you. And yes, we have Dr. Sultan Halimi. He got his PhD from Japan and histopathology. We have in the Kabul University of Medical Science Department, and also we have Dr. Ibrahim Kamal, Professor Ibrahim Kamal. That's they are. Be proud of them. They do this, but as I mentioned, that's the difficult or the challenges is doing this, making a slide, and the diagnosis is okay, but we asked Dr. Sultan Halimi. He was in Tokyo University, and he got his PhD in Japan. We proud of him, and we do. I asked to communicate with you. Thank you very much, and I asked Dr. Sachin, that's for communication between us and our pathologist colleagues in Japan. Thank you very much. Arigatou gozaimasu. Gracias. And shukran. Thank you.
Thank you. Thank you very much, Dr. Pirzad. Thank you very much. It's a time to say goodbye.
Okay.
Hariga, yes. I'm trying to learn Japanese. I think before I come to Japan, I should learn some Japanese.
Yeah.
おやすみなさい。
おやすみなさい。Good night.
Yes.
はい
Good night. Thank you
お
very
疲れ
much.
様ありがとうございました。木村先生、お疲れ様でした。
どうもありがとうございました。どうもありがとうございました。またお願いします。
どうも、失礼します。
ありがとう。
Thank you very much for
Thank you very much.
Thank you. Thank you. Goodbye.
Thank you very much. Bye bye.
Thank you.
Thank you.
Thank
See
you
you next
for
time.
supporting.
Thank you.
Thank you.
おやすみ。
こんばんは。